This grassroots health video on the key fundamental aspects of vitamin D is presented by Dr. Sunil Wimalawansa. Dr. Wimalawansa has been researching vitamin D for over 4 decades and is considered one of the world's leading experts on vitamin D. His extensive background includes working with vitamin D in the laboratory setting, applying his vitamin D knowledge, working with patients as a medical doctor, and facilitating clinical trials involving vitamin D.
Hello, today we are going to discuss about the fundamentals of vitamin D with the view of understanding some of the myths and confusions related to this important micronutrient. So let's start with the term vitamin D, which consists of 3 components. One is a parental component of vitamin D3, which is the one should be used in clinical practice. D2 is a plant or yeast-generated vitamin D, only restricted for vegans who doesn't like taking vitamin D3, comes from sheep. The second one is a calcifidiol, which is a 25-hydroxylated vitamin D. So it's called the 25-OHD, which has a specific indication to use in clinical practice. I will show some of these a bit later. The third component, which is the most active component of vitamin D, which is the calcitriol, it has the 3 hydroxyl groups. So it's a 1,25-dihydroxy vitamin D. So other than this, there are a bunch of analogs, synthetic analogs made out of these 25-hydroxy D, and mostly from the 1-alpha hydroxylase compound, which is indicated in chronic renal failure. So here are the 3 molecules. So you can see on the top part of the screen, we call it calciferol, which is D3, 25-hydroxy vitamin D calcifidiol, and the calcitriol. And this slide you can go back and review later because it has got a lot of information about these concentration in the blood, dissociation contents, and half-lives. So half-life, so D3 is about 24 hours compared to a few hours of calcitriol, and it's about 2 to 3 weeks in 25-hydroxy D. This is because of the vitamin D binding protein, the affinity. And lastly, the concentration of blood from D3 and 25-hydroxy D is about 900-fold higher than calcitriol. This is one of the reasons, no matter how much calcitriol you give, it is not capable of getting into peripheral target cells like immune cells. So giving calcitriol will no benefit but causes side effects in these patients. Now I'm going to show you there are 2 fundamental systems, vitamin D systems in humans. This is again an area, it's a lot of confusion, but I'm trying to simplify it so that easy to understand. The first one, the endocrine system, everybody knows and had been described and well tested over the past about 50 years in vitamin D science, is primarily involved with the calcium and mineral homeostasis, and its product in the system-wise is the musculoskeletal system, but also parathyroid gland predominantly depending on this hormonal form of vitamin D. That is calcitriol in the circulation, which is, as I said, is about 900-fold lower than the 25-hydroxy vitamin D. And so the level of calcitriol in the blood is depending on the 25-hydroxy D, which come from the liver, because that's one predominantly get into renal tubular tissues via active transportation system called myelin tubulin. So they can extract this 25-hydroxy to cells like renal tubular tissues, muscles, skeletal cells, and also fat cells. But in renal tissue, this is the way they get vitamin D. In contrast, there's another system which is every other cells in the body, which is what I call peripheral target cells, like immune cells. It's having these intracrine paracrine actions and genomic function, and also the membrane function. These are predominantly depending on D3 or D2, not necessarily 25-hydroxy D. So as you see that the second system may not work properly and optimally if anyone is supplemented with 25-hydroxyvitamin D, because D3 is the one these cells depending on this non-endocrine system. And this D3 and small amount of 25-hydroxy D getting into these cells through diffusion. There's no active transportation. Therefore, they need to have a 900-fold higher concentration of calcitriol in the system or circulation so that it can get into these cells. So, in vitamin deficiency, the level of vitamin D and 25-hydroxy D are very low, below the threshold of diffusion. Therefore, these cells are getting very low amount of D3 and 25-hydroxy D. Therefore, the production of calcitriol within these cells, again, like immune cell, cardiovascular cell, brain cells, is very much hampered. So you can imagine that the production of these are hampered within these cells. These cells are not going to function optimally. Therefore, vulnerable to diseases, disorders like autoimmune diseases. So very easy to explain why you get in diseases if you think the mechanism of not getting enough vitamin D into these cells. So just a single slide on endocrine vitamin D system is predominantly on work on calcium, but also act on the other system as well with the FGF23. And it's necessary for the musculoskeletal functions. So in the absence of that, you can have a rickets in children and osteomalacia in older people, like weakness, falls, and low reflexes as well, just like hypothyroidism. So these endocrine functions are depending on this regular delivery of 25-hydroxy D. So the liver functions are crucial to get the adequate 25D to renal tubules, so that the renal tubules can generate calcitriol and secrete it back to the circulation. That's why we are calling it the endocrine function. So this 125 dihydroxyvitamin D coming out of renal tubules act on the parathyroid tissues and musculoskeletal and fat cells to a certain extent as well. They do not have, the extraction is due to megalin-cubilin active transportation system which need energy. So let's move to the second system in a little bit more detail. It's an intracrine, paracrine, which means that actually within the cell and the paracrine with the adjacent cells. So the calcitriol go out and stimulate the next cell, their neighboring cells. And the membrane is actually the D3 itself has an effect, direct effect on the membrane to increase the membrane, reduce the membrane permeability and the membrane stability, like in basement membrane, endothelia, things like that. So D3 is crucial for all these functions. And remember again, these the entry into these cells is primarily via diffusion. Although there's a small component can get in through what's called endocytosis, but the amount, while we don't know exactly, but it's supposed to be a smaller component. So that itself is grossly insufficient to maintain their full functions. So let's have a look at it, how vitamin D system works. So I told you two systems of vitamin D. Firstly, we generate the vitamin D through ultraviolet B rays, convert in the 7-hydroxycholesterol to pre-vitamin D, and then converted to the D3 in the skin, which get into the circulation bound to vitamin D binding protein, because these are fat soluble components. Then since we are not getting enough supply, then and also the dietary vitamin D is very little. Therefore, many people, especially in the winter period in the northern and southern climate, need to rely on vitamin D supplements. All of them be converted in the liver to 25-hydroxyvitamin D, which then generate 125-vitamin D in the kidneys, as we said, to benefit the musculoskeletal system. So that's a well-known hormonal system. Whereas every other peripheral target cells are depending on the D3 predominantly and small amount of 25-hydroxy-D getting into the cell. The reason is a small amount of 25-hydroxy-D getting in because it's tightly bound to vitamin D binding protein, compared to D3 is less tightly bound to, so that it's a free form, can easily get into the diffuse into the peripheral target cell. So this is another key biological point to understand. So this enabled the autocrine, paracrine, as well as a genomic function within this peripheral system. For example, here the immune system, it activates all immune cells and fight against, enabled to have a robust immune system to fight against respiratory tract virus, for example, as in the seasonal flu, influenza, coronaviruses, and intracellular bacteria like tuberculosis. So this way they prevent three important areas. One is a microvascular thrombosis, cytokine storm, which causes death basically, and acute respiratory distress syndrome and pneumonia, etc. So with the sufficiency or adequate concentration of intracellular production of calcitriol, not circulatory, and allowed to rapid recovery from these disorders. So that's the way how vitamin D helps us. So briefly, let's look at the pros and cons of vitamin D supplement. There are so many types of supplements available. Firstly, is a generic, economical micronutrient freely available every country without a prescription. And it is basically extremely cheap compared to every other medication. And D3 is the only supplement should take almost all except vegans. And there's no place to take analogs or metabolites of vitamin D as a vitamin D supplements. There are a couple of exceptions which I'll show in the next two slides. And in the West, for example, in the US, it costs about $6 to $8 per year for maintenance of serum 25-hydroxyvitamin D. And if you buy a little bit expensive one, it could be even $20 per year. If you buy a whole bottle of 50,000 capsules, for example, which contain 100 capsules, by the way. So this is whereas it's used as an adjunct therapy in the hospitals or treatment, it's only cost about $2 because all you need is the 4 to 6 capsule of 50,000 IU vitamin D to rapidly increase the serum level necessary to overcome infections through the immune system, as in the case of SARS-CoV-2. So for those incidences, we need to maintain the serum 25-hydroxy level 50 nanograms mil and above, up to about 80 nanograms, either through daily or at least once a week supplements, or by daily sun exposure. People who are in the tropical countries, they have a sunshine all the time. So either way, it's fine as long as you have a daily supplement, because that's the best way to get D3. So Vitamin D status is determined by measuring the 25-hydroxy vitamin D, nothing else. So when you're requesting to test for vitamin D sufficiency, please only request the 25-hydroxy D. No 125-hydroxy D or no metabolites, anything. Those are unnecessary and impossible to interpret those data and waste of money. For example, 25-hydroxy vitamin D, which is calcitriol, do not provide vitamin D. It's completely misleading, and you cannot even interpret that data, except in renal failure. So the second important point of which is in many of the micronutrient has threshold. So up to that, giving more has very little benefits. Similarly, at the beginning level, a deficiency may not have any effect on any biological or physiological effect. So again, I'll show that a couple of graphs to understand this important function. Now, let's look at, because a lot of people are asking what's the best way to get sun exposure to maximize vitamin D generation without getting harm. So, for example, if we need about exposure about the upper body particularly, about a third of the body exposed to direct sunlight, not through windows, and between 10:30 a.m. and 1:30 p.m., which is the best time where the zenith angle of ultraviolet rate comes acutely so that it will penetrate the skin to generate vitamin D in the skin. It's a fair-skinned person can generate up to about 315,000 international unit a day by doing that. So that also gives a clue that the average requirement of the day should be around 10,000 international unit, not 400 to 800 as government recommended. So these recommended amounts are based on the musculoskeletal effects only. Even more, actually, it's designed to prevent rickets in children. So that is the fundamental way the governments and the government-appointed bodies has calculated the amount of vitamin D necessary for an adult. But as you said, that this is a fraction of vitamin D necessary to raise the level to 40 to 50 nanograms per mil in the blood. So this is about almost like tenfold less than what what needed to keep healthy. So these concepts are basically 30 years outdated and reaffirmed by the so-called Institute of Medicine report. They indeed went back and did exactly the same mistake by sticking to Ricketts model, and even more that they had a significant statistical error of calculation which made it even worse, their recommendation. So how does the vitamin D supplementation work with reference to the two physiological system I mentioned a few minutes ago? So renally generated calcitriol coming from renal tubular cells is necessary to have a necessary supply of 25-hydroxy D. So if somebody is on vitamin D3, they may not get enough supply in the absence of liver functioning fully. So D3 will convert it to 25-hydroxy D as long as your liver functions are reasonable. Whereas peripheral target cells like immune cells need D3 predominantly. 25-hydroxy D get in, but the free component in the blood is very small. Therefore, the amount of getting is minuscule. So because of the D3 issue, and depending on that, on the peripheral target cell, daily D3 administration is the most preferred way to get vitamin D3, not only as a supplement, but also, even more important, while somebody is in the hospital. So intermittently taking vitamin D, anything more than every 10th day, is really less optimal. And if you're taking once a month or once in 3 months, it's really like a placebo. It doesn't work. And calcifidiol, which is 24-hydroxyvitamin D, should not be taken as a routine vitamin D supplement because it does not provide the D3 benefit to any peripheral target cells, and you will not develop the robust immune system with a small amount of 24-hydroxy D. Having said that, if you give larger doses like 250 micrograms, that will get into the immune cells and rapidly increases the immune function within few hours. So that's another thing. If time permits, I will touch that as well. So when this vitamin D metabolites and analogs, which I mentioned, can be used or should be used. Here's the two examples. One is for calcifidiol. When is they indicated? I specifically said that it is not indicated as a vitamin D supplement because it does not provide D3. So, however, people who had a bariatric surgery or having severe malabsorption syndrome, severe celiac disease, for example, or some people need to increase the serum 24-hydroxy D level rapidly within hours, as in the case of acute infection, for example, COVID. In that case, calcifidiol is really life-saving because if you give the right doses, it will get into the immune and other cells and will help the immune system to function better. So if you want to give 24-hydroxy D for even those circumstances, it's important that it will be administered with D3 for a longer, broader actions. And finally, the calcifidiol is 20 times average more expensive than generic vitamin D3 called calciferol. And also it has significantly more adverse effect. So why anyone would want to take calcifidiol or 25-D as a routine supplement? So this slide shows the calcitriol and its analog, the indications. So primary indication for 1-alpha-hydroxy products or calcitriol is those with the renal alpha-hydroxylation deficiency. In other words, the people with severe renal failure, chronic renal disease. Their life is depending on providing calcitriol. Having said that, over the last about 15 years ago, there have been many studies showed that giving calcitriol itself has, although improved the quality of life, the longevity and the complication is not significantly reduced. Then they realized that however, if you add the vitamin D3 with calcitriol, it significantly changed, a game changer. The combination of the two are essential in those with chronic renal failure. So as other rare genetic disorders like there are many genetic disorders, the vitamin D resistant rickets, for example, hypoparathyroidism and pseudo hypoparathyroidism. All these can be very beneficial with the right doses of frequently administered calcitriol. Remember, this half-life is only a few hours. Therefore, to get those benefits in the hypopara and pseudohypopara, either calcitriol has to be modified as a long-acting agent, or you need to give about 3 times a day. Once daily does not work. So in these circumstances, the 1-alpha-hydroxylated vitamin D, like calcitriol, could be life-saving and very important. But it should not be given as a replacement therapy for any other condition, osteoporosis, etc. It doesn't work, except the side effects. So there are a couple more additional facts with the vitamin D. Overexposure to the sun, UV rays, causes erythema and skin damage, and even cause skin cancer, not melanoma, other basal cell carcinoma, etc. Therefore, overexposure to sun must be avoided. If one need to be on the sun for like beach, after about 30 minutes, it's strongly advisable to apply sun blocking creams, UVB resistant creams, and then back in the sun for protection. Similarly, in the sun, it's always advisable to use a brimmed hat so that eyes are protected as well as wearing sunglasses. So, on the other hand, excess or exposure to the sun will almost never produce excess vitamin D that causing hypercalcemia. This is because as soon as the skin recognizes that they're producing more or exposure to UVB and producing more pre-vitamin D, they are getting destroyed by the feedback mechanism. So skin itself has a feedback mechanism to prevent excess vitamin D3 getting into the circulation. So therefore, no possibility that skin overexposure to sun causes hypercalcemia. It's a myth. So one more important facts related to vitamin D and the sun exposure. Those who are in the equatorial region, like in Africa, the average serum 25-hydroxy level is about 47 with up to 30 to 65 depending on remember their skin is very dark, so very little it's getting, because that's designed to prevent overexposure and skin damage and cancer. However, when dark-skinned people living in temperate countries like Germany, Scandinavian countries, and UK, for example, or northern part of US, there's a very little possibility they generate any vitamin D for about 7 or 8 months of the year. If you look at their serum levels, it's about 15, 5 to 21 is the range, compared to 30 to 65 is a natural serum level of these people should be. So no wonder that, like in SARS-CoV, there was a 7-time higher death rate and hospitalization with those who are the dark-skinned people, Asian and African American living in UK, for example. There are many studies that have been published. So this is the reason behind their higher morbidity and mortality. So what are the benefits of maintaining the physiological 25-hydroxy level? In addition, if you maintain with the 30 minutes of active physical activity, any kind of activity, gardening, homework, anything. I'm not a fan of gym-based exercise because it's not necessary, but it's no harm going there. But what you need is a physical activity without spending money. So this is known to reduce active and chronic disease burden, including, this is only one method can have been shown to reduce Alzheimer's disease. None of those expensive drugs. And also it reduces hospitalization, premature deaths by 50%. But it's going to take some time to establish benefits in chronic diseases. In addition, if you have these two combinations, maintenance of vitamin D and micronutrients and physical activity, it has been shown that it can reduce the doctor's visits, hospital visit by at least 50%, therefore cost reduction. Another fundamental things one need to know about micronutrient in general, and particularly applying to vitamin D, is it's a threshold micronutrient. So let me explain what is threshold micronutrient is. So unlike pharmaceutical agent, usually the dose response curves a straight line, and actually it doesn't plateauing off. It can go up and then suddenly it causes all the adverse effects. Whereas in threshold nutrient, it comes to a point, threshold, beyond which no matter doubling, tripling your micronutrient will not have a benefit in ordinary people. There is very small group which I'll talk about later, but generally it gets plateau off and there's no point giving doubling or giving 10 times beyond that. Any micronutrient, it doesn't help. Similarly, when the deficient with micronutrient, assuming that you are already giving cofactors like magnesium, K2, etc., even then, giving the standard recommended doses like 5,000, 10,000 a day will have zero effect. in clinical point of view. So doing a research study in a deficient patient as we recommended in a 3 months, 6 months clinical trial will guarantee that end up with failure because virtually none of them will reach the sufficient level in such a short time of few months. Unless these patients were given or subjects are given upfront loading dose like 1,000, 2,000 or 4,000 international unit, maybe one time, maybe daily basis 50,000 unit capsule, so that their level elevated from here to here within a week, for example. Then that routine daily doses of 5,000 or 7,000 will have a significant beneficial effect you can see and document by your clinical studies. So if you're having a vitamin D deficient patient, especially in the shorter studies like 6 month or even 1 year study, it is a must to give loading dose of vitamin D, significant amount, at least 200,000 units as a loading dose. It does not cause any adverse effect. We and others have done many studies, hundreds of studies using this one. In fact, some uses 400 to 600,000, which I think is a little too much, and 2 to 300 is more than sufficient to push from near zero level to about 40 nanograms mil of mean level. However, it must be followed up with the daily doses, otherwise that level will come down quickly within weeks back to where it was. So secondly, the most responsive area of this dose response curve is those who are between about 20 to about 30 milligram. So those patients will, if you're giving 10,000 units a daily, they will have a significant amount of free D3 and 25D to get into those cells, necessary target cells, and improve their function, and therefore they will clinically get better. So basically, I'll identify them as there's a little effect, demonstrable effect, but somebody with a close to sufficiency and they're already sufficient as enrolled in many of these recent large mega vitamin D trials, as in VITAL study. But half the patients vitamin D is sufficient. So giving 2,000 to IU for a sufficient person, doing nothing. So concluding that the vitamin D didn't reduce cardiovascular disease or cancer is a disservice for the scientific community because of the lack of understanding the biology and physiology of vitamin D and how it interacts with the physiological systems. So the response rate, as I said in the previous curve, diminished when they reach in the threshold, what we call in business called a diminution of return. More and more you give, but you get a less and less responses. So once you reach a plateau, further increase of vitamin D or serum level will have very little benefits. So most of the general conditions, people have shown that about 30 nanograms per mil is, if you maintain it, can overcome many of them. But there are a lot of other conditions I'll show you in a minute, will not even touch by 30 nanograms per mil, as it was recommended by the Endocrine Society guideline in 2011. So it has been estimated that it covers about 40 to 50% of the needs of human, not the needs of people. So for metabolic disorders like diabetes, obesity, cardiovascular, and this condition require the minimum of about 40 nanograms per mil with a range of 40 to 80 nanograms per mil, which is safe and is a therapeutic range. So this has to be maintained over the longer period to get their metabolic and system-based benefits, particularly if you're doing long-term studies in a chronic diseases like cancer. This has to be maintained over 4 to 5 years to see the difference between the control versus the interventional group. So doing a study for 18 months with a cancer or heart disease is really worthless and should not be funded by any agency. So remember that both D3 and 25-hydroxy-D involved in the protecting different body systems because their thresholds are different. So the minimum level need to overcome there are other diseases, for example. The musculoskeletal system, as we discussed, is about 20 nanograms is more than enough, whereas the diabetes and things needs about 30 to 40. Whereas the infections, cardiovascular diseases, autoimmune disease prevention, and all-cause mortality need minimum of 40, preferably 50 nanograms per mil. Despite all this data, something like 8,000 clinical publications over the last 15 to 18 years, governments and medical societies are continue to do the same mistake of recommending that 400 to 800 or some cases 1,000 international unit, which is a drop in the bucket in disease prevention point of view. Secondly, in the latest Endocrine Society guideline of 2024, make it even worse. They are recommending one dose of 800 international unit for all ages. It's impossible that kind of a suggestion is clinically useful to anybody. So when you look at the minimum level again, 20, 30, 40, all are based on the researchers, their own bias and the systems they're interested with. Somebody working in osteoporosis or musculoskeletal disease will say, okay, 20 micrograms is more than enough, therefore take 1,000 micrograms and you'll be fine. 1,000 international unit, that'll be fine. Whereas somebody working in the cardiovascular say, no, 30 doesn't work. You need to have minimum of 40. So these are all biased, driven different minimum level, not the patient and the disease prevention minimum level. So condition like I mentioned, the chronic diseases, particularly like cancer, infection, both acute and chronic, sepsis, particularly there's 11 million people are dying from sepsis each year globally, autoimmune diseases, and all-cause mortality can be reduced with having a minimum level of about 42, in my preference is 50 nanograms per milliliters. By doing that, you can cover the 99.9% of the population's need, not only the disease coverage, and that will reduce the disease burden and indeed the healthcare cost, which can negatively affect some entities. So let me show you the graphic format, what this different level looks like. Oh, prior to that, let me give you one more information about the calculation of the necessary vitamin D levels on a daily basis using body weights. Because giving one particular dose as recommended by the Endocrine Society without giving attention to the disease condition or the body weight is really meaningless. So the easiest way to calculate this one is this particular three tabs. Those who are with a non-obese average adult requiring about 70 to 90 international unit per kilogram body weight. Whereas moderately obese, it's about BMI is 30 to 39, it increases to 100 to 130 international unit per body weight. Those who are morbidly obese, they need a higher amount, 140 to 180 international unit per kilogram body weight. This, you can see that the amount here with the morbidly obese person is about 20 times could be higher than the average body weight person. So recommending the single body weight to cover all of them is really an expensive way of doing business. It doesn't work. So what we need is to have one serum 25-hydroxy serum concentration that covers at least 99.9 of the disease entities and the population. So this is the 15 nanograms per milliliter, which covers 99.99 of the population and the diseases. Therefore, you don't have to worry about the community vitamin D sufficiency, which to improve the community health and thereby improve the well-being of the society and improving the productivity of their work and cutting down the absentees, etc. This is what we need to aim for. So let me show you two slides. This from the grassroots of actually work by Dr. Professor Heaney in 2014. It's a fantastic slide showing the response rate on the y-axis and the intake or serum level of 25-hydroxy-D. Either one you can take it here. When you look at the musculoskeletal disorders here, and a certain level will produce the better results. But that particular level adequate for musculoskeletal, in this case pregnancy or cardiovascular, will only produce about a third of the benefits up to the given person. So giving third of the benefits for pregnant mothers to reduce complication is out of the question. They need the 100% protection by giving the right dose and the right serum 25-hydroxy level. Whereas in the case of infection and the autoimmune disease and all-cause mortality, they only cover about the 5 to 10%. So you can see that this threshold mechanism which I discussed here, Dr. Heaney has shown it graphically. What's that mean? The dose necessary to control the disease tremendously varies. For example, if you extend this line this way, you can see that the dose here may be about, the serum level could be about 20, here could be about 40, here could be about 60 or even higher. So that's what we are talking about in the next slide in more details. Here what you're looking at is the serum hydroxy concentration in nanograms per milliliter and the reported, this is average by many studies, the percentage reduction of disease condition or improvement of symptomatology of diseases. For calcium metabolism, it's something like 50 micrograms per nanograms per milliliter is sufficient to overcome about 80% of the problem. Muscle function balance, prevention of falls, reflexes, 20. In the case of osteoporosis and prevention of fractures, and prevention of secondary hypoparathyroidism that causes osteoporosis and fractures, you need a little bit more higher, like 30. We discussed about this one, metabolic disorders like obesity and some cardiovascular disease, they need about 40. And immune system particularly need a minimum of 50 nanograms per milliliter. The small group of subjects or the patient I'm talking about is like the cluster headaches, migraine, resistant migraine, drug-resistant psoriasis, immune disorders like MS, and asthma. Again, these are drug-resistant disorders. They are going to require minimum about 80 to about 130, 140 nanograms per milliliter range in their serum level to overcome the disease. People have shown that if we maintain that, they get about 80% reduction of the symptomatology very quickly. However, these should be managed only by experts ideally from centers with expertise in giving very high doses of vitamin D safely and without complications, as shown in this particular slide. So I'm not going to read that, but I'm going to show you that if you achieve the level up to about 80, we can reduce the human disorder burden and hospital admission by about 50% in 99.9% of the patients. You can see that the benefit tremendously to the families, community, and indeed for the health department and the government by cost reduction. Higher doses above that, a higher level about 80, need to be managed by the experts scattered around the globe who are doing this particular aspect, managing very well, preventing the patient developing complication. For example, they should avoid all calcium supplements and any other calcium-related supportive diets, for example, to really minimize excess calcium absorption. And there are other things they do to prevent complications, potential complication from higher levels or high intakes of vitamin D. So let's move on to have a quick look at the broad causes of vitamin D deficiency. And I'm also going to show you what causes vitamin D resistance, which we briefly discussed a couple of minutes ago. So the vitamin D deficiency primarily is coming from the inadequate sun exposure due to our lifestyle and place you live. And as a dietary supplement, the diet itself has got very little vitamin D. So dietary supplements becoming more and more important with the change of lifestyle and the indoor lifestyle and air conditioning and that kind of thing, which lesser and lesser exposure to UVB. To add that, of course, there are other things like pollution. Air pollution will filter almost all UVBs, and you can stay in the sunlight and you may not develop any vitamin D. Then the malabsorption syndrome, particularly arising from a bariatric surgery, pancreatic insufficiency and things, as well as rare issues like vitamin D binding protein abnormalities, including the malnutrition and nephrotic syndrome. Therefore, the carrying capacity in the blood is significantly less, and therefore the free vitamin D also left less in their circulations. So let's look at the other end of the vitamin D resistance syndrome. There are a whole bunch, actually. I just want to give a flavor of it. And the defective 25-hydroxylase, which is the liver enzyme, that any liver abnormality can cause hepatocyte abnormalities. There are many. Commonest is alcohol intake, and then, of course, the cirrhosis. Anticonvulsant drug, retroviral drug, they are not causing vitamin D resistance, but increase the catabolism of vitamin D. Therefore, the half-life will reduce dramatically. It's almost like 80%. So they need more frequently, higher doses to maintain or prevent vitamin D deficiency. Then in the case of chronic renal disease, we already discussed that in the absence of defective 1-alpha hydroxylation, it can be only overcome by giving 1-alpha analogs or calcitriol as a medication. Then this is the genetic forms I briefly mentioned: vitamin D dependent rickets, type 1. And sometimes these patients need 50,000 capsule daily basis, even children, to raise their serum level to about 30 or 40, because it simply doesn't happen. Similarly in the hypoparathyroidism. So this problem is all these causes the target organ deficiency syndrome related to unavailability of the vitamin D. So the goal of vitamin D treatment in the community or public health point of is to keep people healthy by keeping the population of vitamin D, which I recommend is 40 nanograms per milliliters, not 50 due to multiple reasons. So the 40 is the accepted level in the community without any testing whatsoever. And you can give the reasonable doses of vitamin D to keep them healthy, which is the cheapest and most economical way of doing that. In selected groups, ethnic groups, for example, can be make them sufficient by giving food fortification program using their ethnic food, giving added the right amount of vitamin D to their commercial diets. So the range we are recommending is 40 to 80 nanograms per mil, which covered about actually 95 plus of disorders with this range. Here's a slide from the infection and autoimmunity last year in the paper for a couple of reasons. This is the more elaborate graph from what I showed a little while ago from grassroots, originated by Dr. Heaney. Here, what you're seeing is the health benefits with the maximum response because it's a threshold nutrient. You cannot have indefinite responses. And here, looking at it, the serum 25 hydrox concentration in nanograms per milliliter. And the safe physiological range is 40 to 80. With the safe maximum variability, some people say it's 100 and others consider it as 150 nanograms per ml, depending on their own expertise and biases. Beyond that, it's a chance of getting hypercalcemia is significantly higher. So the adverse effects goes up with the more higher doses above 140, 150 nanograms per milliliter. As I said, to give higher level to maintain that, you must be treated by a specialist who's very familiar with this kind of handling high doses, particularly in a specialized centers. Now, extraskeletal benefits occur beyond the musculoskeletal benefit, but is continuous for a while until it hits about the peak ranges. Now I'm going to show you this particularly rare disorders of what I think is about 0.01% of population, which is a very small amount. In addition, people with a large bone mass, and I already said that intestinal pathologies, bariatric surgery, and they're going to require the higher levels, higher doses as well as a medication like anti-epileptics and antiretroviral agent that stimulate the hepatic P450 enzyme catabolic system. They'll have a very higher turnover of vitamin D and its metabolite. So they need higher, much higher doses of vitamin D. So healthcare workers need to be aware of these two also, rather than just giving a standard single dose for the age or each and everyone come to their clinic. It doesn't work in threshold micronutrient. So this slide basically summarizes the diseases and condition improved by vitamin D, and there are other set of condition can prevent the disease onset like cancer, cardiovascular disease, obesity and metabolic syndrome, and indeed infections. If you have a robust immune system with the serum level of 16 nanograms per milliliter of 25-hydroxy D, you won't, highly unlikely that you are going to get a symptomatic COVID, for example. You will get COVID virus, but body will be able to eliminate them very quickly without sometimes you're not even aware of. And all this adds to the morbidities and mortalities. Example here is cardiovascular diseases. Vitamin D deficiencies also, as we touched last slide, significantly impaired the immunity. Robust immune system, now we know this needs minimum of 50 nanograms per milliliter continuous basis to have overcome the infection. In addition, vitamin D deficiency, we also know that it accelerated the aging process that experts will discuss in this conference. In addition, vitamin D deficiency increased the risk of COVID, symptomatic disease, ICU admission, and indeed deaths. You saw this from the statistic during 2020. The 80% of the people who died from COVID are the elderly people in nursing homes and the residential homes because they are at the multiple comorbid conditions, and almost all of them had a vitamin D deficiency. So they were the first set of people who died from COVID due to significant vitamin D deficiency. So this causes significant risks of death, complication, and this adds to escalating healthcare costs. So rather than cutting that, healthcare department then should think about actually changing the whole process of thinking by changing the micronutrient deficiency and thereby cutting cost, hospitalizations, and improving health of people. So this slide basically summarizes what I said in my basic presentation regarding the fundamentals related to vitamin D. So deficiency causes microbial infection, predominantly viral. It clearly harms pregnancy, increases complication, cesarean section, stillbirths, and the growth and the quality of brain development in infant. Muscular disorders, particularly rickets, osteomalacia, osteoporosis, and fractures. Chronic diseases, we discuss about the cancer, autoimmune diseases, etc. And then other non-traumatic acute illnesses also increases with the vitamin D deficiency. And indeed, the metabolic disorders, and well known is diabetes and obesity. Cancer and autoimmunity is another specific category. Vitamin deficiency not only initiate these disorders, but make them worse and increase the mortality from these diseases. Thank you for listening.